when you have this ischemic cascade, I'll just go back up to this. You have lots of excess calcium entering, overexciting the cell, and essentially, when the cells are overexcited, they get destroyed. So that's sort of the good and the bad of the calcium. I'll come back to the bad part of the calcium as we move along, because I think this next one is a really interesting one in terms of antioxidants and reactive oxygen species and these free radicals. So another part that happens when you have calcium, too much calcium, coming into that receptive neuron after you've cut off all the blood flow to that part of the brain, is you get these free radicals or reactive oxygen species. So something that an antioxidant would actually mop up, hopefully. But these free radicals, these reactive oxygen species, are also excitotoxic. So they also lead to cell death. So what happens is you get more of these more calcium coming in, and then chemicals are actually entering the cell. These free radicals are being produced inside the cell, they're coming from the outside, they're just flooding the cell with all these signals that will essentially just say, the cell says, I can't take it anymore. It sets off its signals to say, shut down, it's time to die, and the cell will actually die. This is a real uplifting Just realized that. I might have to change one of the next lectures to look at something more positive about the brain. Maybe just learning in general. So again, what's happening is these cell death signals are turned on because all these toxins, all this calcium, all these free radicals are just flooding the neuron, and the cell experiences death, or what's called basically the genetically programmed cell death process of apoptosis. So this cell death experience, or this apoptosis process, is what happens when we're developing. So when our brains are going through their sculpting phase, there are all these signals that tell the neurons to turn off. But those signals, that apoptotic, those genetic signals, do not just go away. They hang around, they wait for something. And in this case, they wait for all this cascade to take off, and those genes will turn on and ultimately self-destruct the cell. Like I said, real uplifting. No. So this is one that I can imagine that we can skip over, but what's happening is this is the bad of calcium, that you have these excitatory neurochemicals being released, opening up these pores, all this calcium coming into this receptive cell and setting off these signals within the cell, so this oxidative stress, so these reactive oxygen species that will then set off signals leading to cell death or apoptosis, or other signals that will just chemically destroy that cell.
With regard to the glutamate, some people are now taking glutamine supplements.
Mm-hmm. Yeah.
It's supposed to help performance, but I wonder, given what you're saying here, if that's a good idea.
Right. So no, I mean, again, I think it goes back to the whole idea about taking any chemical. So I was touting the idea about nicotine, how that can enhance all these neurotransmitters, but this anything that's causing this imbalance in calcium could be ultimately toxic. So yeah, no, I mean, I guess if you have decreased levels of calcium, that's where you'd want to up your levels. But it's hard to, I mean, we know when we have decreased levels of calcium because our bone structure gets weak. But the question is whether that's actually happening, the same thing is happening in the brain. We're not really sure about that. So this is where, again, but that I think in terms of a stroke, what you might want to do for a treatment is to stop these pores from being open to allow this calcium to come in, or take high doses of antioxidants, so maybe a bushel barrel full of blueberries to stop that process so that these signals will hopefully not be set off and the neuron will die. I'm trying to make it a bit more uplifting. I know it's a serious topic, but it's yes. Okay, so again, I mean, so the next part that we've already kind of talked about. So I mean, this is where now it's the damage starts to spread. But The other problem is you have loss of vasculature, the structural integrity. Essentially, the blood-brain barrier gets broken down again, and you have more blood flowing, or you have more swelling taking place, and then that can cause this secondary set of brain damage. So it's really, again, I think this is the part where you need to go in for a surgery if there's a break in the vessel, or if there's a break in the artery, that you need to have that fixed. But again, fixing the blood-brain barrier is a bit of a more challenging task. That in terms of a long-term prevention or long-term treatment, this might be something that we go after to reduce the secondary wave of damage. So I've already talked about this. This kind of summarizes everything that I've just went over, and I don't want to get too much into the nitty-gritty of what's happening at the cellular level, because I think what's really interesting, and so this is probably a nicer picture of that, but again, just to keep in mind about all the calcium that comes into a neuron, the high concentrations of calcium that set off this whole intracellular cascade that ultimately will lead to signals that are already present in our cells, in our brain cells, that lead to a sort of self-destruction or apoptosis, so cell death. Right. So I gotta really start rolling here. So you not only have the immediate damage from where the blockage takes place, but then you also have, as this tissue becomes destroyed, as the inflammatory processes try to take place, as the brain tries to heal itself, what can often happen is those processes will cause damage around that area. So then the cell death starts to spread out, which again is not a very good thing to have happen in your brain, because then the symptomology becomes worse, the clinical manifestation of this. So let's get into that. So the clinical manifestation. So I think this is, again, to think about this now, not necessarily as a serious issue, which stroke is, but just to understand brain function and to understand the clinical picture of a stroke, to show how when different areas start to get loss of blood flow to them, what happens. So it really gets into how different parts of the brain are involved in different behavioral functions. So it's the clinical consequences are based on the anatomical regions of the brain affected. So this is something, we can get an understanding of why somebody is showing, paralysis in one side of their body because of where the stroke may have taken place. So that's why, because the brain has these specialized centers that are responsible for different functions. So you have our motor center of the brain, we have our visual center of the brain, we have our auditory center of the brain, we have our speech production center of the brain. So when those parts of the brain go through that whole cascade and they start to die off, then you see these really particular neurological deficits. However, as it is, the brain is not just this, we're not only using 10%, we're always using our entire brain. So you have to have this integral function of the entire brain to actually produce behavior. So, it's an oversimplification to say that when this part of the brain is damaged, you'll have this behavioral output. It's not just that simple. Plus, the brain can often overcome damage to itself. So when damage occurs in one part, there's, it's a rippling out effect that other parts will also suffer. So I just want to, keep that in mind. But there are some really interesting clinical pictures of what, what the outcome of a stroke would be. So one of those is a speech disorder. So it's called, aphasia. That's A-P-H-A-S-I-A. I got these out of it. Well, I won't. It's not. I should blame the source. But it's aphasia, so it's a loss or impairment of the ability to communicate. And I think this is kind of an interesting. So the location again. So it's a common consequence of left hemisphere stroke. 33% of all stroke patients show these signs of aphasia. So I just want to point this out. There's two parts of the brain on the left side that are really important for language. So the language production center is called Broca's area, and the language understanding area is called Wernicke's area. So it's often this impairment in the ability to speak or to understand language. And it's because you can see that there's quite a bit of blood flow. I mean, these are kind of deep in this area, but there's a lot of blood flow to those parts of the brain on the left hemisphere. So when you have damage to that Broca's area, you can't speak properly. And when you have damage to Wernicke's area, you can speak properly, but you can't understand what people are saying, which I think, again, is a really interesting part, or interesting function of the brain. And these parts of the brain are very, very small. So, you know, that's where you can say that, yes, they've had damage to Broca's area because they can't produce, let's say, meaningful language. Unilateral neglect is, I find, a really interesting one as well. And I think this really summarizes it quite nice. It's inattention to an entire side, or the entire universe, opposite to the side of damage in the brain, which is really, I mean, it's one of these fascinating things, and I don't have any really good videos, but to show a person who has this unilateral neglect is just unbelievable. So one part of it is called visual neglect. I mean, the range is really quite a large range, 13 to 85%. But essentially what's happening is, so, and again, it's often, for whatever reason, I don't think it's, well, it's actually, it's pointed out here, is the right side of the brain is the one that when you have right side damage to this, to the upper part of the brain, so the parietal cortex really, so right in here, that's when then you neglect the entire left side of your universe. So I'll just put up the, what sort of the representative picture looks like. So here's a picture that a person with a right side stroke, right parietal lobe stroke, is supposed to copy. So they say, okay, here's a picture of a clock, copy that clock. They're ignoring the entire left side of the clock. Here's a house, copy that house, left side is gone. Copy the cat, the left side of the cat is gone. So it's one of these weird things, and I guess you could never really know what it's like to experience this until you actually experience it, but it's like the entire left side of the world just doesn't exist. And they often say that, you know, that's not their hand, that's not their foot, that's, you know, it's fascinating. And it's, for some reason, it's, you know, it is that right side, that right parietal lobe, so this little strip here that's really involved in sensory functions, but it's also taking in the visual world, it's telling you where you are in the world, it's orientation, it's all these different things that, you know, when there's damage, the opposite side is actually, you know, basically disappears. So, and that, it's actually related to this anosognosia, which I had to practice saying again because I'm on camera. So the patient has a lack of awareness of their paralysis or of the diseased part of their body, again, on the opposite side. So this is as well on the right hemisphere. So you can see here the percentage of people who have stroke in the right hemisphere, that same parietal lobe, 28 to 85% of these individuals have this lack of awareness of the diseased part of their body, of their paralyzed, let's say, left hand, whereas 0 to 17% happens in the left hemisphere. So it's very similar to that unilateral neglect, except they're not neglecting the universe, they're neglecting their body in this case. So it's a bit more specific, it's a bit more of a smaller world for them to neglect. So again, it's on the right side. So you have the sensory area, so you can see the blood flow coming in, this middle cerebral artery going in and projecting quite a bit of blood, or sending, sorry, I think this is, there we go, sending quite a bit of blood to that sensory area. And that sensory area, when there's a blockage or a burst of the blood there, when it goes through that cell death cascade, then you start to, you know, you could get paralyzed, so it could affect the motor areas, or you could lose sensation. And the patients will often say that, you know, that's not my arm. That it's, you know, again, it's amazing how your brain can play tricks on you like that, where you can be convinced that that paralyzed side of your body doesn't even exist. And people, I read this, that people will make up stories. They'll say, somebody else is in my bed. You know, the doctor will say, whose hand is that? I don't know, somebody else is in my bed. You know, so it's, again, it's the brain can do these amazing things that, you know, we go back to the bigger picture. The mind doesn't have to play a role in this. When you have actual organic damage to the brain, it can really change how you function in very abnormal ways. Delirium is another one. So again, just getting back up into the frontal lobe world. So you can see here that this anterior cerebral artery, you have a lot of blood flow up to this frontal lobe, so this whole area. And you can imagine when you have a clot here, the frontal lobe starts to get destroyed. And, you know, I mean, 25% of people who have that, and they have, you know, again, these mood alterations, so probably depression, hallucinations, altered attention, all of that, which is indicative of damage to that frontal lobe. And this, I just put this up here because I think this is really, again, the importance of that frontal lobe. And this is a relatively new finding, but patients who have delirium are 5 times more likely to die in a hospital or within a year compared to stroke sufferers who are without delirium. So again, whatever it is about this area, or it could be just because if you have blockage here, you know, that anterior cerebral artery goes back to feed other parts of the brain, but it's something about, you know, I mean, I like to think, I don't like to think about this, but I think about this, if there's damage here, that then, you know, it has a worse outcome. And then the final one is just the idea about post-stroke depression. So again, this is going back to the idea about, you know, is the depression a cause of the damage to the brain? So when you have a decreased blood flow to this frontal part of the brain, is that what causes depression? Or are you depressed because, you know, you can't move the left side of your body? And so this, I think, is a pretty good study about that by saying that if you compare stroke patients to orthopedic patients with similar, you know, left side paralysis, let's say, the rate of depression is higher in the stroke patients. So, and there is evidence that, again, this frontal lobe, when the frontal lobe gets damaged, then there's a high incidence of this post-stroke depression. So, I mean, it's probably a bit of A and a bit of B, that it's both, but it does seem that it's damage to the brain that leads to this, this mood change or depression. So treatments, again, just to try to get this wrapped up. So I talked about this clot-busting drug called tissue plasminogen activator. And so that's one of these where, you know, if you see the warning signs of a stroke, if you see that, you know, there's a headache or you have loss of function in one side, you have about, I think now the Stroke and Heart Foundation has said it's about 4 hours to get treatment with one of these clot busters. So you have to get into the emergency room, you know, and get this clot buster to actually get rid of that clot so that you don't go through all that cell death. The problem here, so that works for 80% of strokes, but the 20%, if you give a clot buster, is going to have the negative effect, right? So you're giving this thing that's causing more blood to flow, and if you have a hemorrhagic stroke, you're in big trouble. So you know, if you could actually, you know, understand that what the clinical picture is between the ischemic versus the hemorrhagic stroke, you could probably, you know, these treatments would be more effective. Yeah.
Would they do a CT scan?
Yeah, right. So they probably would do a CT scan to see if there's a big blood flow, right? So control the brain swelling. So if you miss that window of opportunity, you know, decrease the brain swelling often, again, because after the hemorrhagic stroke, so that you can, you know, so that your brain doesn't swell and then go into this secondary phase of damage. So then there's all these, I'm just going to put this up, the idea about neuroprotectants. So I think this gets into the antioxidant story, the neurochemical blockade, all of those more, I guess, experimental treatments that would help hopefully protect the brain, but then also block that, you know, that cascade of all those secondary events, which I looked quite a bit. I looked for a good hour or so for any drugs that are, you know, in clinical use or in clinical trials, and I couldn't actually find any. So it's, you know, still in the really experimental phase. So it's, you know, it's still to come, I guess, as the more we understand about these post-stroke events. And then the last one is the, let me just jump to this constraint induced therapy, which I think, again, is really, it's the idea about, again, training your brain. So if you have paralysis in your left side, you know, people have the tendency to then just use the right side. They have that compensatory plasticity. So the idea is say, okay, you're not using your right hand, you have to use your left side. And what will happen is and this has been done experimentally. There's a guy out in Lethbridge who does this with rats, is that he can train these rats to now use their left side and to reach and grasp things even after that side has been paralyzed. And they can show that the brain is now rewiring and going around the damaged areas and, you know, rebuilding itself. So again, it's that idea of, you know, you're teaching the brain how to fish so that it can feed itself forever. It's really, I mean, it's a really interesting way. It has a lot of experimental evidence that it works, and it's, you know, it's something that you don't have to rely on these experimental treatments or these drugs that could have just more of a quicker effect. So I think, oh, prevention. Okay, so prevention is to, again, it's more focused on the ischemic attacks, how to reduce blood clots from happening. So, you know, aspirin, medications that help prevent additional blood clots from forming after you have an ischemic event, things like that. That's, you know, basically that plus, you know, the real hard stuff is not eating those Big Macs, not eating deep, you know, heavy fatty foods and things like that. So I think I should stop there. Sure. See how that works. So I will be able to post this video. I'm going to look at it when I get home, and I'll make sure it looks smooth and everything. But I can put it on because it, you know, again, it might be worthwhile to just for you guys to watch again, and then for anybody who actually missed it. So are there any questions before I? Yes. Yeah, that, so right, so if they speak multiple languages and they have a stroke that affects that speech production area, do they lose the ability to communicate in both languages? I've actually, so I have one just story about this, that I met this guy. He was a back bartender, and he knew German and English, and he had a stroke. His German was gone, but his English was still there, but he could understand German. So the part of the brain that could, the vernix area that understood language, it was still bilingual, but the part that produced speech was, you know, half cut off. So it's, again, you know, it's hard to predict what will actually happen, but that's at least one case that I know that it only affects one language. Yep.
I took a CPR course, and they gave an example of somebody who had a stroke at a fitness center. I guess got dizzy, fell off the treadmill, and then she was very kind of aggressive and almost in denial when they were trying to help her.
Wow.
And they almost kind of said this can be one of the symptoms, which kind of leads back to that other slide attack.
Yeah. So the
effects.
Right. So the effects in the frontal lobe. I mean, the irritability and the personality change. Yeah. I mean, it's so that's interesting.
They had to argue with her to get her to
yeah,
hold
that's
her tongue and raise her arms.
Yeah. I mean, and that, like, again, that I think that's a clear sign that it was probably frontal lobe mediated, and then that, you know, yeah. Yes.
Just to follow on that, the most famous incident in the last few years was the Richardson that was on
Yeah.
Apparently she was barely moving and she fell, and then she said she was okay. I'm sure that ski instructor is traumatized forever after.
Yeah. Oh yeah. I mean, that's the thing. Like, again, how your brain can confabulate, basically. Yeah.
You mentioned calcium levels in the brain, and you mentioned if you're lower in calcium in the body structure, we know that.
Right.
Do we ever find out, or do they test how much or what level the calcium is in the brain?
Yeah, I mean, there are probably ways, but I mean, we can do it obviously, and like if you do a spinal tap, let's say, you could probably get calcium levels, but it's not something that you typically want to do. I mean, because it is so invasive. So I mean, there's probably ways you can image it, so that, you know, from when I started out being able to see through a brain, you could probably develop tracers that will detect the levels of calcium. If you're first, then we'll come up here.
The person who's ignoring their left side, let's say, if you said to them, where is your left hand, how would they respond?
I guess they would just say it's not there, or they would probably have this, the idea that, well, you know, even if you point it out to them and say, this is your left hand, you know, they might then go into the story that, no, that's not my left hand, that's your left hand, or, you know, so it's really, it's a weird situation of really denial, neglect, yeah.
Yes, my older brother's a medical doctor in California, and he had several strokes. He lost all his mathematical tables. He didn't remember anything to do with multiplication.
Yeah. So those real.
But not only the speech can be affected, but the mathematical.
Yeah. So then again, there's you know, I mean, I think that's the thing about acquired brain injuries is you don't, you know, you, like, so for example, the Wernicke's area, if you already understand language, you know, then your Broca's area will be fine. You can, like, if you lose Wernicke's, you can still produce language. But if you're born with damage to the area that's meant to understand language, you can't produce language then. So it's, I mean, yeah, so once you have this damage after you've got all these tasks or whatever, this knowledge, then it's interesting to see what functions you actually lose. Did you have? Yeah?
You said too much calcium is bad. How do you know? Where do you stop making calcium?
Yeah, well, I mean, I guess the nice thing about the brain is there are a lot of buffers for calcium, so that I mean, you know, I'm not a doctor, but I'm a PhD, but I would recommend, you know, for, you know, to take calcium supplements for sure. I don't think there's any harm because your brain can deal with, you know, fluctuations. It's not just a set, there's, you know, probably a range of calcium that your brain can deal with and buffer and take out, but, you know, as you're losing calcium in your body, that needs to be replaced for sure, and I wouldn't worry about effects on the brain unless you're really, you know, I mean, it would have to be toxic levels. All right? Oh, one last one?